Welcome to the December 2025 Curious Cases webinar. These webinars are meant to be informal and interactive, so please feel free to respond to my questions and ask your own if you have any. So we move from inflow to outflow and beyond. Curiosity fuels innovation, which leads to path of discovery. And the curious case webinar is a great way to look at different cases that we otherwise will not be sharing. And sharing is important for learning because we may not see all these cases during our clinical rotations, but if we stop dictating in the middle of an interesting case and go over it with our fellow colleagues in the reading room and our friends, we learn from it. And I'd like to acknowledge, my mentors, Gautam and Greg, who both uh, gave me this thought of stop dictating and look at the most interesting case of the day that whoever would have in the reading room. And it's something that we have tried to continue over here. I would like to acknowledge my other friends also at URMC who have helped me with doing this, and of course our resident Adam Dyke who has helped me um, with finding some of these cases. This is just an illustration of what we are looking through. Cardiovascular imaging is a big topic. We look at veins, we look at arteries, and of course the four cardiac chambers. I'll try to keep this interactive. Feel free to answer any of the questions, and please feel free to question if you have any questions about any of these. So we'll start off with this first case. This is a CT chest and a CT abdomen in a patient who was presenting with edema in lower extremities and increasing abdominal girth. Presented to the ED, and as you can see, the first thing that you would usually do is do a PE study, and we followed that up with a CT abdomen also. Based on these um, four images, or sorry, two images, what do you think should be the next step?
I think when we say history, then we choose that option. Yeah, look for the history of DVT.
Great, great. Looking for a history of DVT would be good. There are some things that are more than that, right? More which don't explain.
Yeah. So I think cardiac MR probably for looking for masses extending out there.
Great, yeah. So MR would be great. Actually, B, C, and D would all be part of the follow-up regime because at some stage we would have to do all of these if we are thinking beyond the regular thrombus. So we of course got all of them, and I am only showing you one image, which is the PET, FDG PET image. And this lesion was very hypermetabolic. So now, what would you think would be the most likely diagnosis based on these findings? So we had an image of a abdomen, upper abdomen, a chest, and also a pet. So it's an intensely hypermetabolic mass. And what would be the most likely diagnosis based on that?
So C,
C is a great answer. And actually, D would have been the most common cause of this finding because we are seeing signs of ascites and we are seeing signs of some hepatic congestion. But C is the most likely diagnosis. Very good. So it's a rare tumor, but it's one of those tumors that, as cardiovascular imagers, once we see it, we know what it is, and we can immediately point our clinician colleagues in that direction. And these are some two articles that I thought were very good, looking at what the clinicians would do with leiomyosarcomas. Typically, these would require surgical resection, and it's a complex surgery which would involve both vascular and a GI surgeon, and maybe also a cardiovascular surgeon, depending upon what is the extent of the disease. So in this series, these they found that they had a very good survival rate. It probably could also be depending upon what stage that tumor was identified. But this is a case of a primary IVC malignant tumor. More commonly, we would see examples of secondary tumors invading the IVC, commonly being HCC, RCC. Sometimes you could also get retroperitoneal sarcomas and adrenocortical carcinomas, which can invade directly into the IVC and extend the heart. So here we have if you go back and look at these images, we have ascites, we have some heterogeneous enhancement of the liver, we have this mass, which it is not entirely hypoattenuating. So immediately our suspicion is higher. Typically, also with IVC thrombus, we should not be seeing secondary signs such as ascites and pulmonary nodules around the bronchovascular bundle, which would suggest direct extension of metastasis into the lungs along the pulmonary arteries. From a surgical standpoint, this is something I realized much later. Typically we talk about the extent of the disease and we are done. And then you get a call from the surgeon and he says that I need to know more about this. What's happening to the hepatic veins, what's happening to the renal veins, and what's happening to retroperitoneum, because that changes their approach to surgery. And depending upon, I mean, this patient is of course not a surgical candidate, but we might have surgical candidates in which tumors are confined completely within the lumen or within the wall. And in those cases, this classification system is very useful: upper segment, middle segment, and lower segment, when we define the upper and lower extent of the tumor. This is a companion case of a renal cell carcinoma, and we can clearly see, we can use ADC maps also if you're doing MRs, ADC and diffusion weighted images showing restriction, again in a mass which is big enough that typically you would need the mass to be at least centimeter or two before you can start using ADCs, because we run into issues of respiratory motion artifacts also. Say in our case, if a cardiovascular mass is at least 2 centimeters, only then we would run the ADC, and not for tumors or lesions which are smaller than that. Different case. This one was a spinner, and it's definitely one of the zebras that we rarely see. But again, once you see it, you know it. And this is a abdomen MRV, kind of a late venous stage. We can still see the artery. You can see the contrast in the veins very well. And we have this lesion which extends almost up to the right atrium. So what would we do next? Anyone?
So, as because I was doing the first one, so I'll try.
It's
So
okay.
it looks like it is a filling defect, hypointense filling defect, but it looks like a mass-like filling defect. So um, I would not just stop with anticoagulation. So we'll have to do something.
Hmm.
Um, so uh, what should we do? Like for abdominal part, I think. Yeah, consultation with surgery is not wrong, but PET-CT will probably give us whether it is hypermetabolic or not. I
Yeah,
see there is some extension to the heart, so cardiac MR is also helpful. But if we have to go with all these,
yeah,
maybe PET-CT.
yeah.
I'm
Definitely,
not certain.
PET would be a great choice. Uh,
Uh-huh.
Unfortunately, this was done at a place which did not have PET, and they straight away went for surgery. So because this was done at one of those remote sites, you probably have also might be experiencing this, that the you don't have that great a control of what happens next to the patient. And of course, the description included all the things that you talked about, Dheeraj. They talked about this. We talked about the tumor. We talked about extension into the right atrium, and the whole surgery team went in. They had a cardiac surgeon, they had a vascular surgeon, there was a hepatobiliary surgeon, again because they are all anticipating that this is some kind of a malignant tumor that would require more than one. At the surgeon, he came back and said to us, I opened it up and it all fell out completely. Like there was no invasion to any of the vessel wall, and it all came out. So now, if we come to this, in a, in our our understanding of these vascular tumors, I think these are the things that we try to see before we talk about could this be malignant, could this be benign, or could this be something else. One is luminal expansion, which will be seen in acute thrombus also. Second is wall thickening. Now that is a very specific sign which would be which should raise a red flag for it being malignant process. Same for extraluminal component. Enhancement can be used to differentiate benign from thrombus. And do we see any additional lesions? So when we look at these, five different criteria, we can kind of narrow it out or rule some certain things out. This, if you apply all these criteria to this lesion, we know that there is a luminal expansion. We don't see a wall thickening. We don't see an extraluminal component. It does enhance, so it's definitely not a thrombus. And as far as additional lesions are concerned, it's kind of difficult to see on this image. But if I go back, you can see that this is extending from the pelvis into the veins. So this was an example of now what would we say?
So I think it is probably B,
B.
because
Very good.
because it didn't. Yeah, I don't know. Yeah.
Yeah, very good. So leiomyomatosis, it's one of those rare entities that you see you don't see very often, but when you see, it's like that eureka moment, and you tell everyone to stop reading their cases and come and take a look at it. It's one of those rare entities, but we can see that, and typically these can extend all the way up to the right atrium, and sometimes they could mimic metastatic disease also if those lyomyomos are broken off from that primary tumor. But the key thing is to look for leiomyomas in the pelvis and look if we could identify something going through the enlargement of the pelvic veins. Again, these are all things that you would see more in retrospect rather than upfront. And this was a classic example of a leiomyomatosis. Very few cases have been described. I think they showed something like this at RSNA case also, this year, which is why I thought I should probably include this. Um, and then mostly it's surgical resection depending upon the extent of the disease. Again, if it goes into the right atrium, typically a cardiac surgeon would also be involved in these surgeries. So let's move on to our next case. Again, this is a curious case. We saw somebody, one of the residents picked it up in the reading room. And I think Susan and I and Kate and everybody started looking at it. It does not look like a typical lesion. What would we do next? Anyone? What can we do on this CT to suggest something else? Okay, which can help us identify what could this be? So definitely, these are curious cases. So we're not going to do a follow-up after anticoagulation. We can look at B, C, and D. And the easiest or the probably most logical thing first would be to see in the patient's EMR or in the patient's jacket to see if there is any additional imaging. If we just look at these images, there is something which is hypointense, uh, hypo. There is some nodularity also, which extends from the which is present in the SVC. It also goes into the brachiocephalic and internal jugular vein. This is a patient who has had an aortic valve replacement. Again, same thing, we can see it over here. So typically your SVC wall is paper thin, it's barely perceptible. And if we see a wall thickness, then we should start thinking of something which is more than just benign. So looking through the patient jacket, we found this knee MR image. This is a post-contrast fat suppressed sequence. You can see this is the fat suppressed sequence, which showed a delayed phase, which showed an enhancing mass. So based on these two images, we did raise the possibility that this could be some kind of a malignant process rather than just being a benign lipoma. Typically, a lipoma will be homogeneous in attenuation. It should not have wall enhancement and definitely not have mural nodularity. And this turned out to be a patient with superior vena cava liposarcoma metastatic from that knee primary. The PET is difficult because the mural nodule is very small and it may or may not show the extent of the tumor. More importantly, is to see if this tumor, once you are thinking that this is a malignant tumor and not a benign tumor, to think is it confined to the vessel or it could be extending into the mediastinum or neck. Again, from a surgical perspective, this becomes important because if it is extending outside the vessel wall, it involves a vascular surgeon as well as a thoracic surgeon, you know, to resect that primary that lesion, which is what happened in this case. So what was seemingly simple appearing, fat containing lesion in the SVC turned out to be a 6-hour surgery for the two surgeons because they had to resect, and the extraluminal fat component is very hard to distinguish on CT. MR can sometimes be useful, and that again further down in location we can see that mural nodularity in that mass. Again, PET is not very useful if the tumor is or the solid component is very small, and this applies for liposarcomas at other locations also. So
So
let's move on.
that's a great case, Avi. If I can ask you something. So
Sure.
you mentioned about the wall thickening. So how do you know that there is wall thickening, not just contrast outlining the lesion?
So I think that's why you want to have a delayed phase to make sure that you can see that. If you
Okay, okay,
don't have a delayed phase, you want to do an MR. And actually, if you
okay.
go back to this, see we got the CT, they got the PET,
Uh-huh.
and it's only after when this was discussed in the tumor board, and it's only then that we suggested that they should get an MR because we will see the wall component and the extraluminal component better on an MR, which
Okay,
can be
okay.
hard to see, on a CT.
Yeah, great case. Never seen a case like that. I'm
Yeah,
sure others have not seen.
curious case. Yeah, these zebras. This is the day for the zebras. So moving on, cardiac tumors and tumor-like lesions. I think how do we describe them? You got to think of where is the location, what is the size, imaging characteristics, and then what else can we tell them besides the location and the extent of the disease? Sometimes it's easy, sometimes it can be tough. So let's go through some of the cases which can be challenging to diagnose. Just if you're looking at single imaging modality, this is usually a diagnosis that comes out through multi-modality imaging. Again, typically when we think of PET, we think of FDG PET, but when to do a DOTA date PET, this is important because paragangliomas will be would more likely be DOTA date PET, and it's a very specific marker for identifying them preoperatively without doing a biopsy or without doing any kind of excision. And different phases, radiographs are tough. We could see metastatic disease. Echocardiography is what probably these patients will get first, or a chest CT for some other indications, and then these might be identified. This is an example of a paraganglioma that's identified on a CT chest being done for chest pain. And MR is useful to characterize, to look for chest wall invasion. And ultimately, we come down to PET, to see what's the metabolic profile or is there any metastatic disease anywhere. And then also choose what location to biopsy. In case there is a more accessible metastatic disease, it's easier to biopsy that than to biopsy a cardiac tumor. Cardiac tumors would usually be biopsy depending upon which chamber they are. LV tumors will usually require some kind of cerebrovascular protection to make sure that you don't get tumor emboli when they do a biopsy. So let's look at this. This is a 35-year-old patient who presents with increasing dyspnea and cough, diagnosed with new onset heart failure, dilated cardiomyopathy, and echocardiography demonstrating four-chamber enlargement and mobile left ventricle mass concerning for thrombus. So what would you do next, based on that?
So I do not think anyone else is taking cases today, so I'll put me myself out there. So uh, I would probably go with cardiac MRI. So that is what we do.
Great. We'll go with that. Dheeraj, have you any experience with doing cardiac CTFs for masses in those patients who have defibrillators or who cannot get MR for some other device implants?
Yes, we do the CTA because you already alluded that because of the site of the lesion, you can decide whether it is a what kind of tumor it is. But uh, my experience is limited to differentiating clot versus soft tissue,
Hmm.
and I think MRI is the only modality that can do it, or PAT if it shows uptake. But I'd like to hear your thoughts here.
Great. So we'll go through it. Let's talk about that. So this is the four chamber, the short axis views of the same patient, and we have got not just one but two lesions. RV is typically tough to see for with echocardiography, and that's why we, sometimes are unable to. They are unable to identify lesions in the RV. So two things that we're seeing here that scream straight off the bat are a very prominent trabecular pattern in both the ventricles, the left ventricle and the right ventricle. And then of course we have got these two lesions, right ventricle and left ventricle. Right, RV lesion is the one that they were not suspecting. So based on that, I think using our current guidelines, we would usually talk with about hypertrabeculations with thrombi. Previously, we would have called this non-compaction cardiomyopathy, and biventricular non-compaction would be the diagnosis. It's one of those rare entities. Um, I think the newer guidelines are changing and no longer calling it an isolated cardiomyopathy. This is a longer inversion time sequence. Again, depending upon the scanner, you would choose on a 1.5 Tesla. Usually it's 600 Ti. Uh, in my limited experience, we have tried to look at dual energy iodine content of lesions to differentiate thrombus from masses. Again, you need to make sure that all three of those images are three data set are acquired similarly, and you need to standardize that. We usually use the same delays as you would do for a liver mass protocol, so using that and try to get at least the venous or the delayed phase as a dual energy acquisition to look for iodine content of that. So what we have here are our biventricular thrombi, and again, this is the recent guidelines which suggest that we shouldn't be using the term, non-compaction, except in those patients who are young, who may have cardiomyopathy, and in which case they should do genetic testing for that. So hypertrabeculation is the preferred term, and that's what these two guidelines papers are talking about. There are separate criteria for RV, prominent hypertrabeculations. The easiest that I find is, if trabeculae are almost 50% of the septum, then probably we should think about right ventricle also being involved with hypertrabeculation. These are some of the criteria that can be used, which are used. Again, more commonly used is, end diastolic non-compacted to compacted ratio of more than 2.3. Stacy's and systolic one is also there. And this is trabecular mass is kind of hard, but you can do that in difficult cases also. All right, so moving on to our next case. This is a 30-year-old patient who presents. Oops, did I lose my screen? Sorry. Who presents with recurrent hemopericardium, and the cardiologist calls and say that did we perforate any cardiac chamber during the pericardiocentesis. So based on this finding, what would we want to do next? And I think the answer is probably cardiac MR, since we are all cardiovascular imagers. But again, in those patients who cannot undergo a cardiac MR, we can do a multi-phase cardiac CT also to kind of get some of the idea of what entity we are looking at. So these are the images from the CT. This is a ECG gated CT. This is an MR, and then this is a PET MR of the same patient. And we can see that this is like a large mass originating from the right ventricle lateral wall. It has got contrast. It has got soft tissue component. The soft tissue component has FDG ability also. So based on these findings, what's the most likely diagnosis?
So whenever we look at right heart tumors, like I think about angiosarcoma.
Mhm. Great, very good. So that's the most very important thing. Most important thing is whenever you have a mass-like lesion originating from the right atrium free wall, then you got to think about angiosarcoma. That's the most common site for that. And again, this is the MIP image of the PET MR. You can see that there are multiple lesions beyond the cardiac chambers. So I think this is important because then we can choose which lesion to biopsy rather than going to trying to biopsy this mass, which is more risk. We can biopsy one of the pulmonary nodules or maybe one of the lymph nodes in the mediastinum, which are easier. And in this case, what happened was that they did a first biopsy of the pulmonary nodule. It turned out to be hemorrhagic, and they came back and said that this it's non-diagnostic. Are you sure this is an angiosarcoma? And I think at that time you start thinking, well, could am I dealing with something else? They are not getting it, and then we tell them that don't do an FNA, rather than that try to do a true cut or get a larger sample size, and maybe you'll get that. So second time they did go into that. They don't typically don't want to use true cuts because of risk of hemorrhage. But pulmonary nodule is still easier to biopsy than hemorrhagic cavitary mass in the right atrium. One more thing that sometimes we could see is presence of thrombus within this pseudoaneurysm, which is why I think first getting a PET is useful to identify the metabolic activity or the most metabolically active nodule, and then go after that. We did a biopsy of that, and then this was the cardiac angiosarcoma. Again, we can see the ERG ERG stain confirming that this is a tumor of vascular origin. And different MR sequences can be very useful to identify. This is again, we can see the necrotic part and the enhancing component. It would be more difficult to reach this through a transcatheter biopsy. This was a angiosarcoma. These are rare cases, but they visit you back. And unfortunately, this was a patient when I was a fellow at UW, and this patient came in to look for the right coronary artery aneurysm. And what we can see over here is this mass, there is enhancement, this is thrombus, This is a longer inversion time, 600 Ti, four chamber MDE sequence, which shows the non-enhancing component, which is thrombus. We have the enhancing component, which is the mass. Unfortunately, in this patient, this was encasing the right coronary artery, causing a RCA pseudoaneurysm because of that mass. Different patient. We are doing a staging CT in someone with known abdominal malignancy, and we come across this lesion. It sits right at the inferior atrioventricular groove, right atrium, right ventricle. Is it intracardiac? Is it extracardiac? Is it valvular? Again, MR is great to start that. TE is typically difficult to evaluate right atrial lesions. It's great to look at left atrial lesions because LA is immediately posterior to the esophagus. If you can't do a cardiac CT for any reason, we can do a cardiac MR, prospectively gated four-phase, to see if we can characterize that. Same lesion. These are the three different images from an MR, four-phase 3D GRE, and this is the non-contrast, this is the post-contrast, and we can see that there is increasing contrast within this lesion. So one thing that sometimes can be useful is if you're looking at a suspected primary from some other lesion, see what's the enhancement characteristic of that lesion on your MR and see if this suspected lesion has the same enhancement pattern or not. If it is same, then probably it could be metastasis. If it does not has the same pattern, then maybe we are looking at something different. This patient underwent surgery, and this turned out to be a hemangioma. And this turned out to be a hemangioma basically. And again, if the key thing is if you use the same criteria that we use to look for hemangiomas in liver, we can try to apply those similar criteria over here also, and that can be helpful in sometimes identifying them or at least pointing them towards that direction. This is a different patient. This is a staging CT for someone with known bladder cancer, and then you find this mass in the mediastinum. It's nearly at the level of transverse oblique sinuses. Of course, we do a PET after that, and on the PET we don't see any FDG uptake. So then the question is, what else could this be? And you could try to characterize it with MR, and using similar criteria, we can sometimes see the key thing on the MR is we see this is a T2 hyperintense lesion. This is a fat suppressed sequence. The serpentinous, signal voids are what you would use as a criteria for looking at hemangiomas, and you can suggest that this is probably not the same lesion that we are talking about. Again, this patient underwent surgical resection, and this turned out to be a pericardial hemangioma. This is moving on to different cardiac chambers, and we see probably something like this more common than any primary, vascular or primary cardiac tumor. Metastatic disease is what we would probably see more commonly. So we have this large left lower lobe mass, which extends to the left lower lobe pulmonary vein, and we have these filling defects and enlargement of the pulmonary vein with extension into the left atrium. So again, what would we do next? Probably PET is the best idea when something like this is there, because cardiac MR is only going to, if PET is not there, maybe we could use MR to characterize this. But here our index of suspicion is very high that this is not a bland thrombus, rather this is a tumor thrombus. And the PET, clearly identifies that hypermetabolism within this, which is something that is consistent with tumor thrombus. All right, so we sometimes see cases that completely, makes you think, what am I looking at? And I really want you to look at this case. These are things that we see very rarely, but once you see that, I think it has utility in um, identifying patients at risk, and then taking appropriate action which can be life-saving. So that was the angio run. It's a non-diagnostic CTA for pulmonary artery evaluation. And these are the, static images from the same patient. This is the graph from the bolus tracker. And what we see is very altered flow of contrast. So typically when we inject contrast into the veins, they go through the right atrium, right ventricle, pulmonary artery, pulmonary vein, left atrium, and left ventricle. And after that, we start seeing that going into the abdominal, abdominal aorta and abdominal organs. We see a very different pattern over here. This is all like, contrast is typically higher attenuation than blood pool. So if we put contrast and blood in a container, usually the bottom part will be contrast. And what this that indicates is that there is no movement. The blood is not moving at all. And that's what we are seeing over here. This is a PFO or a small ASD through which contrast comes into the left atrium. It goes into the dependent portions of the pulmonary veins. There's no contrast in the pulmonary artery. It goes into the IVC. You can see an blood IVC contrast fluid level in the IVC. It goes into the hepatic parenchyma and retrograde opacifies the right portal vein. So this was a patient that came early in the morning, and the overnight resident was kind of tired at the end of the day. And the moment I entered the reading room, he asked me, "What should we do? Do we need to re-inject contrast? The tech is calling." And this is not a call for re-injection of contrast, but rather to see if you could palpate the patient's pulses or not. Are they Do they have asystole? And of course, these are just suggestions, but this was a patient with who had asystole, who had a cardiac arrest on the scanner, and we immediately pulled him out. We called the code team, and they were able to resuscitate the patient in the CT scanner room. And we did, of course, a PE study later, and that turned out to be negative. There was no PE in this patient. There's also a hemopericardium we can see over here. Patient had an MI, and the hemopericardium was probably related to that. Cool. Has anyone seen anything like this? Asystole or very low cardiac output on a scan?
Yeah, only in conferences or textbook. I have never seen a personal case.
Yeah.
Thank you.
This is so weird. This is something that, we talked about it we all of us talked about it, and we probably got, uh, it took us, it took, this was the curious case which it took the village to figure it out. So all, this was a pre-COVID time when there would be at least 2 or 3 attendings in the reading room. So it was great. We could just ask them to come over and ask, what are we seeing? And I don't think I had seen anything like this before. Um, I've seen very low cardiac output, which would be, decreased contrast enhancement in the atrium on a PE study, but never something like that.
No, thanks for sharing. Yeah.
So moving on to the next case, this is a central VA ECMO patient who is now presenting with uncontrolled ventricular tachycardia. It's a non-contrast. He's in acute renal failure. There is no the the clinical team is adamant that we don't want to give contrast. Just see whatever you can get from this. And what we see over here is again one of those rare entities that you see. There is high attenuation in the myocardium. We can see over here. There's some low density over here also. but very high density or high attenuation of the septum. And when you look at the coronal, there is this gradient, density gradient within the ascending aorta, which higher density in the aortic sinuses and tubular portion, and then it goes away. So this is a very, rare and classic example of stasis thrombus happening in the ascending aorta. Remember when patients who are on, this is someone on a central VA ECMO, they don't have, um, they have poor cardiac function and poor respiratory function. So VV ECMO would be used for decreased respiratory failure. A VA ECMO is typically used when both there is cardiorespiratory failure. So the cardiac function is known to be poor, and then we are bypassing the blood from the cardiac chambers using these venous cannulas to draw an arterial cannula, which is typically either in a peripheral femoral artery, or in case of central ECMO, it's usually in the ascending aorta. So the part which is below that ascending aorta, below that return cannula, is where stasis can occur. And in this case, this high density was also extending into the left main coronary artery. This was an example of, again, there's not much a core team can do. These already intubated. All the lines and tubes are there. I think we need to talk to our heart failure team and tell them that what we are seeing is probably a hemorrhagic myocardial infarct, which probably thrombus in the ascending aorta. Calciphylaxis is an entity that we can see in uremic patients where there is calcium deposits, and sometimes you can see that low blood pool is seen in anemia, and that there also you can see differences in enhancement or attenuation of the myocardium versus blood pool, and vicarious pericardial excretion of contrast from previous CTA, or contrast from if there is a coronary artery rupture, you could see some contrast blush in the focal area of the myocardium also. But typically there'll be a history of that, or the clinical team would be talking about that as an example of coronary artery injury. So this was a case of a hemorrhagic myocardial infarct. This patient went on to get a total artificial heart because it was so acute. There was no point waiting for the to be listed for heart transplant. He was listed later, but and this is the explant pathology. You can see that there is myonecrosis and neutrophilic infiltrate and band-like areas of necrosis. You can see the myocardial cells here, and we've completely lost them over here. So this was an example of extensive LV hemorrhagic myocardial infarct from a stasis thrombus in the ascending aorta. P study, again, this is probably a repeat of what we can see, filling defect, which doesn't go away after anticoagulation. We do a PET, it's hypermetabolic. This is a pulmonary artery sarcoma. Again, these are the entities, these are the headings that we can sometimes use to help differentiate an acute thrombus from a tumor. Is there wall thickening? It is expanding. Is there enhancement? Again, in a single phase, it can be tough, but if you have a multi-phase acquisition, you can sometimes see that, or we can see a FDG avidity within that. Typically, a bland thrombus should not have FDG more than 2, 2.5. If it's higher than that, usually it indicates malignant process. Different patient presenting to the ED with chest pain. He has had no medical history because he has never seen a doctor. He's nearly 50 years old and he's presenting with hemoptysis. So this is kind of a companion, not really a companion case of the previous case, but here you can see this is a large filling defect, which is thrombus. It's layering in the pulmonary artery, unlike our previous case, which was completely filling. We also see these multiple aortopulmonary collaterals, large aorta, a ventricular septal defect, and overriding ascending aorta. This was a patient with unrepaired TOF who came in with hemoptysis because of bleeding from these MAPCAs. Ideally, these would need to go for IR embolization. presenting with different patient presenting with acute stroke, and what we can see is a large filling defect in the subclavian artery which extends into the arch, and this filling defect is over here. So then, is this tumor or is this thrombus? Typically, we can do a delayed phase, we can do a repeat to talk to the clinician and say that this is probably free floating thrombus. If there is suspicion, we could do a repeat scan. 48 hours would be the earliest after anticoagulation. If it's not getting bigger, we can stay. We typically would do repeat scan in like 2 weeks, and then go to something like that. And these can appear as thrombi. So this is a grading system which is used by our cardiology colleagues, which is called as CADS grading system. And anything that's soft plaque more than 5 millimeters bulging into the aortic lumen is 4. And if it has a mobile component, again, for us to look at a mobile component, we'll need to do a ECG gated scan, which sometimes we can do, which will help us differentiate this entity also. Different patient in an aorta. Here we see multiple masses. There is mural thickening. There is mild enlargement. This is not a single mass, so likely this is not a single thrombus. This is a patient who has a primary aortic tumor. This is a PET MR of the same patient. There is low-grade uptake in the mural nodule. Again, this is something that could not be seen in a patient who has free floating thrombus, or just a plaque thrombus complex. So PET can sometimes be used as a tiebreaker. PET can also identify additional lesions. In this case, there were two additional lesions in the vertebral body which were easier to biopsy, and they biopsied that, and it turned out to be a primary malignant tumor in angiosarcoma of the aorta. More commonly, we could see direct invasion from esophageal cancer or lung cancer extending into the aorta, causing tumor involvement. So again, we can use these criterias, and these can help us, being tiebreakers in differentiating primary tumors versus thrombus. Different patient, are these similar findings or something different? This is one of my colleagues who gave it to me, and there is a large filling defect in the descending aorta. Is it tumor? Is it thrombus? Hard to say. We do a follow up and it's still there. So they went in and did a IVUS ultrasound and the biopsy. This turned out to be just bland blood clots, basically a thrombus in the free floating thrombus in the aorta. This is a different patient, my last patient, patient who had non-ischemic cardiomyopathy and underwent an orthotopic heart transplant. Their clinical concern was myopericarditis because of elevated troponins. If we look at this short axis sequence, we don't see a lot of pericardial thickening, no fusions. Maybe there is some decreased hypokinesia of the inferior wall, but otherwise wall thickness looks okay. There is nothing to suggest a constrictive physiology over here. These are the blood pool images, and this is the late gadolinium enhancement of the same patient. We can quantify the degree of enhancement. This is a near transmural enhancement. So again, this is always transmural enhancement, as you all know, is always concerning for myocardial infarct. So antibody-mediated allograft rejection is commonly patchy enhancement because it's similar to myocarditis, versus cardiac allograft vasculopathy would have similar findings as a myocardial infarct. Because the graft is denerved, CAV can be difficult to diagnose, and that's why we do oftentimes, stress MRs to look at these patients. These are again difficult to treat lesions because stents revascularization can be tough in these patients, and it's restricted only for those who have favorable coronary anatomy. Thank you. Any questions?
Those are some excellent cases. We learned a lot. Thank you so much.
Thank you. Take care.
Thank you very much. We greatly appreciate it.
Thank you.